Good morning, Professor. If I may call you that, you are, I think, technically Professor Dame Sally Davies. You're talking not just to those who are here in this room, but to something in the region of 100,000, sorry, 100 or so. I'm overstating the importance of this inquiry. How could I? But 100 or so people who will be watching remotely. Bear that in mind when you're giving evidence. In a moment, Mary will ask you to take the oath, and then Ms. Fraser-Butlin will ask you the questions. Mary.
Please state your full name.
Do I stand?
If you wish.
Professor Dame Sally Claire Davis.
Take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth. Thank you. Thank you, Sir Brown.
Professor Davies, I just want to start with a brief overview of your career before we talk about some of the detail. You qualified in 1972 and then undertook 2 years of training until 1974. Is that right? And then you took a career break until 1978, returning to undertake further training in London in paediatrics and then haematology training in 1979 to 1982.
Yes.
You then undertook a molecular biology research post until 1985, before being appointed as a consultant haematologist at the Central Middlesex Hospital in 1985.
Yes.
And that consultant post held a specific remit in relation to sickle cell disease.
Yes.
You remained there until 1996, when you were then seconded to the NHS executive as Director for Research and Development for the North Thames Regional Health Authority.
Yes.
And during that time, is it right that you continued with some work in sickle cell outpatient clinics, advising on inpatients and mentoring younger consultants?
Yes.
And then from 1999 to 2002, you worked as the Director of Research and Development for London at the DHSC.
Yes.
And then the Deputy Director for Research and Development for the Department of Health.
Yes.
In 2004, you were then appointed as Director General of Research and Development and Chief Scientific Advisor to the Department of Health.
Yes.
Where your primary work was setting up the National Institute for Health Research.
Which I did in 2006.
And then in 2010, you became Interim Chief Medical Officer and Chief Medical Officer in 2011.
Yes.
Until you retired in 2019 from that post.
September 30th.
I want to take you all the way back to your training before your career break, if I may, so up until 1974. What were you taught during your training about when a transfusion should be given?
I think I was very well taught that no medical intervention is risk-free, and that you had to think very hard about why you were doing something, and that blood and its products was an intervention that had risks. At the time, we were concerned particularly with alloimmunization and febrile risks, and therefore they should only be used when really needed. And so we would judge the patients and when they really needed them. One of my house jobs, kind of allocated, was actually to work with a vascular surgeon for a few months. And of course, during some vascular surgery, the patients do bleed immensely and need significant transfusions. So we would give them what was reckoned to be appropriate.
Could we turn to HCDO 40861, please? It will appear on your screen. Thank you. This is a book that or a booklet that the inquiry's looked at a number of times. It's called Notes on Transfusion, and this edition was revised in 1973. During your house officer years, do you recall ever being provided with a copy of this?
No, I don't believe I was. I think it's useful to understand that at that period, medicine was pretty hierarchical, and so the practice of the junior docs was based on what the more senior doctors and the consultant wanted. But I do not recall it.
And could we turn to page 4, please? And we pick up the second and third paragraphs. A transfusion should never be given without a definite indication. Not only is this in the patient's interest, since an element of risk is associated with every transfusion, but supplies of blood are not unlimited, and with the ever-growing demand for blood, it's imperative that it should not be used unnecessarily. The use of transfusion to correct moderate or slight degrees of anemia that could be overcome as effectively, if more slowly, by other means, seems unjustifiable unless some cogent reason for speed of recovery exists. In some instances, failure to institute simpler and safer, but equally effective treatment earlier leads to the quite unnecessary use of blood transfusion. I understand you haven't seen the document at the time when you were training, but does this accord with what you were told in your training?
Yes, and with my practice.
And broadly, was that the approach taken by your colleagues as well?
Yes, it was normal practice as I remember it. I don't remember being out of the ordinary. Everyone in my hospital, it was called Withington Hospital, it later became the University Hospital of South Manchester, and it's now been knocked down. But that was practice as I remember it.
And then if we turn to page 18, please. We see the heading Transfusion Records, and it notes, a record of every transfusion should be made in the patient's case notes, in addition to the details recorded in the transfusion laboratory. It's not always appreciated that the main reason for accurate recording is the protection of the patient. Again, does that accord with your training and practice in your early years?
Absolutely. We always recorded that a transfusion was made, and generally on the wards why the anaesthetist would do it in theatre.
And was that something that your senior colleagues drilled into you, the need to record it, or checked up that it had been done in any way? My first 6 months were working for an amazing, considerate clinician who was highly regarded, and I think he did drill it into me, but my values are transparency and that you should record things. In terms of the risks of viral transmission from blood transfusion, what were you taught about that during your early years?
I actually do not remember discussion of viral transmission in those early years. We were aware that infections could be transmitted by transfusion because bacterial infections could be, malaria could be, but I don't recall discussions of viruses. But, you know, as a houseman and then an SHO, you were not, I was not involved in the policy discussions, nor was I going to meetings around transfusion.
During your training, what was your understanding of the risks of hepatitis? Was that something that crossed your radar as a junior? I trained in Manchester and did those first 2 years in Manchester, and the most common cause of hepatitis, sadly, was alcohol. Following behind, we saw hepatitis A, and we were only beginning to be aware of hepatitis B. And when you returned from your career break in 1978 and returned to that training period before your consultancy, again, did you receive any training in relation to viral transmission via blood transfusion in that period?
When I was a paediatric senior house officer, my first role, the first year back, no, I don't recall any specific training on that. But of course, once I moved into haematology training, there was discussion about viral transmission and the need to both be able to diagnose hepatitis B, and the query about, we knew there was none A, none B hepatitis, but what was it? And of course, donors or units were excluded if the liver function tests were abnormal in order to try and minimize any transmission.
What was your understanding, and how did the understanding develop during that training period in relation to the seriousness of non-A, non-B?
I find it difficult to recall. The knowledge clearly grew steadily. I have always been very bad at recalling dates, I'm afraid. Family dates, any dates. I failed the 11 plus. I am dyslexic. So I apologize that I find it difficult to remember dates and put things in dates. We heard about hepatitis B, we heard about the hunt. I personally knew a certain amount about it because as a haematologist in training, I spent 6 months at the Regional Transfusion Centre in northwest London. And I must have received more training at that stage there, and I will have visited the laboratories where they did the testing. But the detail and the way that it slowly grew in my knowledge, I don't really know. And I was actually focusing much more on two areas, one which was sickle cell disease, which I came to specialize in, and the other was pediatric hematology and looking after children with blood disorders. So my focus was less on the transfusion, and I felt then, and I felt all the way through my career, that I could rely on the expertise of our Regional Transfusion Centre to give us the best products that they could at that time. And I think my 6 months there convinced me that they were doing their best to stay on top of the latest science and deliver the best they could.
But whatever the date was, you have a recollection from what you've already said that at that stage, tests were being done on donors to exclude those with raised LFTs.
That is my memory.
So plainly, whatever was the seriousness was thought to be, it was serious enough to take those steps to exclude donations.
Yes, everyone wanted blood transfusion to be as safe as possible, but as any medical intervention, nothing is truly safe. There are always risks.
And do you, bearing in mind your difficulty with dates, when do you think you first became aware of AIDS as a risk?
I actually think I became aware of it in the homosexual population well before I became aware of the risks in the transfusion supply. I don't think, along with many others, that I made that connection, particularly at the time. But that doesn't mean that those experts were not making the connection. It's just that I don't recall making that connection before it was highlighted by the transfusion service.
Moving on to when you became a consultant in 1985, you've said your post was the first in the UK to be established specialising in sickle cell disease. Many of those listening to the evidence will be aware of what sickle cell disease is, but some won't be. Could you give us just a brief layman's explanation of it for those who are less familiar with the condition?
Thank you. So sickle cell disease is an inherited anemia, and you have to inherit the sickle gene from both parents to have the disease. If you only have one gene, you are called a sickle cell carrier. And there is an advantage to that if you live in a malaria area, that during the first year of life it seems to protect against infection, against malaria. So that explains why this gene has reached quite high levels in sub-Saharan Africa, Nigeria, Ghana and places. It's also present in the Middle East and India and wherever those populations have migrated to. Sickle cell disease has patients in that group who are SS, the sickle gene from both parents, or S from one parent and another hemoglobin abnormality from the other. C is quite common, D, various others. They're all part of sickle cell disease. So, if you've inherited this, why does it matter? Well, our red blood cells that are made in the bone marrow and circulate in the blood are there to take oxygen from the lungs to the tissues. And as those red blood cells go through the tiny blood vessels called capillaries and through the spleen, as a matter of fact, they have to be flexible and distort in order to squeeze through. And sickle hemoglobin, when it gives up its oxygen, goes into crystals, and the crystals align and distort the red blood cell into that classic sickle banana shape. And that's why it's called that. We can look down microscopes and we can see these bananas of sickle red blood cells. They're crystals. They're stiff. They can't get through the tiny blood vessels, and some of them stick to the blood vessel walls of bigger ones, and they make blockages. The blockages means that no oxygen, because no red blood cells, can go past that blockage. So you get no oxygen to the tissues. So it's a bit like a heart attack. You get a blockage in a blood vessel, no oxygen to the heart muscle, you get pain. And sickle cell painful crisis is when there is pain in the muscles or bones because the blockages don't let the oxygen-carrying red blood cells through. Of course, the blockage can go away and then flow starts again, but if it persists, you'll get, as in a heart attack, scarring. And if it's overwhelming, as in a heart attack, it can kill. And there are horrible sequelae, so dreadful pain crises that, I only understood how bad when I asked one of my sickle women who'd had a baby, how was the pain at parturition, at delivery of the baby? And she said, nothing on sickle cell. I have to say, my respect was always there for my patients, but it went a lot higher. It can be very bad, but also you can get sickling in the lungs when it's called the sickle chest syndrome, when of course you get a vicious cycle because you then you're blocking blood vessels, so you can't pick up the oxygen to take round. You can get pooling of sickled cells in the spleen, and then suddenly they can drop their hemoglobin, to dreadfully low levels, 2 grams, and actually die of it. In the space of a few hours, you can get pooling in the liver, you can get priapism, so a prolonged painful erection that can go on for days and means they will get scarring and impotence later. And about 15% of SS children get some degree of damage to their brain that ranges from actual stroke to just cognitive changes and maybe some learning disabilities. So it can affect anywhere in the body, and it can be catastrophic. One of the difficulties for the patients is that you don't know who's going to be severely affected and who isn't. So it's very difficult, and all we can do, or we could do when I was practicing, was advise the patients to keep warm, to keep hydrated, to use painkillers, and come to hospital if it was bad. Now there are some anti-sickling agents, and towards the end of my practice, we had hydroxyurea that raised another hemoglobin, fetal hemoglobin, levels in the red blood cells, which made it more difficult for the crystals to happen and to align. But in the 80s and until the late 90s, essentially all treatment was symptomatic. SC patients had fewer complications, but pregnancy could be particularly difficult. SD patients, there aren't many of them, were as severely affected as SS. And then, of course, you could get an interaction of the Sickle gene for hemoglobin with a beta thalassemia gene. And if it was a beta thalassemia gene that made no hemoglobin, it was equivalent of SS. If it was a beta thalassemia gene that made a lot of ordinary hemoglobin A for adult, it could be quite mild.
In terms of your post being established in 1985, do you know why your post was established at that particular time as a specialist sickle cell post?
They, at Central Middlesex, established my post because we were one of the hospitals that had a large clinic of patients with sickle cell, and we wanted, I was a senior registrar there, so when I say we, I was part of the discussions. We wanted to really major on it and make sure that our patients in Brent got the best treatment they could, and so that meant we needed to focus on it. And I was appointed because I wanted to do that, but also I had not only the hematology training, but some pediatric training. And of course, that meant I could look after them from birth right through to death. I should say at that time, in the 80s, the median survival was 44.
The inquiry's got an expert report dealing with a number of different conditions, and in that report it also addresses sickle cell disease, and it estimates that there's about 15,000 patients in the UK with sickle cell. Do you recall roughly how many sickle cell patients you were treating at the Central Middlesex when you were a consultant there?
It came and went, and I think by the time I left we had about 600 patients on our books, but some of them didn't turn up for outpatients because they felt well and couldn't see the point of coming when they were well. I always hoped they would, because to look after patients when they're ill, it's very helpful to know how they function and who they are when they're well. And we could talk about prevention and other things. But interestingly, when I reviewed the paper I sent you, it looks as if at the beginning we had rather fewer patients, probably under 100.
But over time that built up?
Yes.
And you think that the Central Middlesex Clinic was probably one of the biggest clinics for sickle cell disease in the UK at that time? It
was, alongside King's, University College Hospital, Birmingham.
And in terms of those with the SS gene, what sort of proportion of your patients had that most serious version?
I would have known that, absolutely. It was the majority. Yeah.
And the inquiry's heard quite a lot of evidence about the UK HCDO, the Haemophilia Centre Directors Organisation, the group of haemophilia clinicians who met. Was there a UK-wide specialty group for sickle cell clinicians?
There was not when I started, but it kind of developed, and it developed in two ways. One, we had the Brent Sickle Cell and Thalassemia Centre, manned, if I can use that word, by wonderful specialist nurses who in fact then trained most of the other nurses and kind of trained the trainer, who set up counselling services around the country. So through that counselling and nurse network, there was a lot of sharing, and we would, between us, have various meetings. But then, and I'm trying to remember when, I think in the 90s, but quite when, we did start to meet as multidisciplinary teams. It was never doctors without nurses, it was all of us together to discuss patients and issues. Probably from the late 80s, early 90s, thinking about when the SMAC, the Standing Medical Advisory Committee report came out. We must have been meeting before that.
And in those discussions as a group of clinicians, as nurses, were there discussions about protocols and guidelines for treatment?
So we talked about treatment. We had at Central Middlesex very strict guidelines for managing sickle cell crises and what should be done. I'm sure you're aware it's very easy to write a guideline. It's not too difficult to send it out and disseminate it. The problem comes, and it's all in the social sciences, and I can bore for Britain on the evidence up till about the mid-teens of this decade, the difficulty of getting people to follow them. We were strong in Central Middlesex on guidelines. Ours existed. The sickle cell ones were followed more than any other. When we asked the young doctors why they followed ours, they said two things. The first was they hadn't been exposed to sickle cell in their training, so they didn't know what to do, so it was really helpful. The second was I was given to stalking the wards and finding the doctors and saying, you didn't abide by the guidelines. That's fine if you had a good reason not to, but if you didn't have a good reason, then that's not right, and make sure you do next time, or I'll be round again. So I stalked the wards about our guidelines and supported them when they departed from them for good clinical reasons.
Can you give an overview for the inquiry as to what the circumstances would be where a sickle cell patient would require a blood transfusion?
So we didn't want to use blood transfusions for sickle cell patients. First of all, they normally run a hemoglobin around 7-8 grams if they're SS, but then blood viscosity is normal. So if you add to it, thinking that they need it because they're anemic, you increase the blood viscosity. And there are cases in the literature of stroke being caused by that raising the blood viscosity. Of course, there are risks with transfusion, not only the immediate risks, but the longer-term risks, alloimmunization, transmission of infection, but the one that very much exercised us was iron overload. So with every bag of blood you give 250 milligrams of iron that the body cannot get rid of. And the thalassemia patients were kept alive and well and functioning well because of regular transfusions, but then they were dying of iron overload, giving them hepatitis, diabetes, cardiomyopathy. And we didn't want our sickle cell patients to have transfusions just because it would make them feel good for a week or two and then have this problem of iron overload. There is a treatment, it's called chelation therapy. Essentially, you give a treatment, a chemical that will wrap round the iron molecule and make it soluble so you can either wee it out or poo it out. The standard, while I was working, was desferrioxamine. In fact, for most of those years, it was the only one. It could only be given by infusion. You needed, for the thalassemia patients or those sickle patients on regular transfusions, to use it as an infusion with a needle under the skin for a minimum of 6 hours and ideally 8 to 10 hours, 5 to 7 nights a week. And it was irritant. It was horrible. That treatment was not what you wanted. But if you gave them lots of blood and you didn't solve the iron overload, then you were going to kill them anyway with the iron overload years later. There are now oral chelators, and now transfusions are not done manually. They are, for people who have regular transfusions, done as exchange transfusions on machines where they take out the old blood. So they're trying to take iron out as they put in fresh blood. And that reduces the iron overload, though maybe they still need some oral chelation. I'm not up to date.
When they put in fresh blood now, is that largely red blood cells rather than whole blood?
Yes. In my day, it would have been in optimal additive solution, and I presume it still is, yes.
But if it's in optimal additive solution, can you explain, going back to the question of viscosity, why that should make the circulation more viscous?
The red cells themselves add to the viscosity. It's not just a plasma, it's a whole blood viscosity that I'm worrying about.
Yes.
So if you up their hemoglobin, you're adding red cells and you're increasing the whole blood viscosity.
But you're also increasing the fluid in which the blood is transported.
No, you aren't. We have, 8 litres of blood in us, of which a certain amount is red cells, white cells, platelets, and plasma. If you pour blood in, then most people will pee out the excess fluid.
Yes, so it's a question of the retention of the red blood cells, getting rid of the excess fluid.
Yes, we balance ourselves out quite quickly, actually.
So in what circumstances would a transfusion, red cell concentrates, be given to a sickle cell patient?
So only generally if it was life-saving. So, if they were infected with parvovirus, that would stop them producing red blood cells for 2-3 weeks. Then their hemoglobins would drop dramatically. The red cell lifespan in sickle cell disease, as I remember it, it's about right, is about 9 to 15 days, whereas it's 110 days normally. So if you don't produce any red blood cells, your hemoglobin goes into your boots, so that's aplastic anemia. We would top them up, a straightforward transfusion. Splenic sequestration, we would top them up. Hepatic sequestration, we would try and do an exchange. Sickle chest syndrome, we would do an exchange. Concern for the brain, and we would do an exchange acutely, but then if we were going to go on long term, we would generally transfuse them. Well, at the beginning of our practice, we transfused them every 6 weeks, but that time became shorter as we understood how if you gave them a top-up, that suppressed their own production of cells. So therefore, you could try and keep the viscosity low and the sickling low, but that was all as practice developed. And as I say, now they do it generally on machines.
And you spoke about an exchange transfusion. Again, could you just briefly explain what that involves?
So you'd have a sick patient, adult or child, and we would sit there, and I even did it as a consultant, and you would essentially try and get as big a needle as you could into the vein, but sickle cell patients have dreadful veins, so it would be very difficult to find vascular access. You'd have a 3-way tap, and you would have the bag of blood one side and an empty bag the other side. You'd suck out 10 to 20 mils, and it would be quite hard work. You'd turn the tap, push that into the empty bag, turn the tap round, and drip in 20 mils or suck 20 mils fresh of donated blood into the syringe, give it to the patient, and start again. And if a patient was very sick, we could sit there for a whole day, 6 to 8 hours, just steadily trying to do this, because what you were trying to do was get the sickle hemoglobin definitely below 30%, and reading some of the documents, maybe, this is a number that I don't remember, maybe it was below 20%, but ideally we would break it into sessions, and you would try and do, 6 units one day and another 4 to 6 the next day, because it was, I got blisters on my hands sometimes doing it. It was really hard work, and for the patient it must have been dreadful. But it was life-saving.
In those contexts, generally how many units were transfused?
For an adult, somewhere between 8 and 10 units usually, as I remember it.
And you've said in your statement that some severely affected patients were given transfusions every 2 to 4 weeks. Roughly, what proportion of your patients were in that category?
It was quite a low number that we had on regular transfusions because of the iron overload worry. I'd love to have had more on transfusions to give them good quality life, but you're always balancing risk with advantage. And there was no way that I could recommend regular transfusions to someone if I didn't think it was the best thing for them despite the risks. And we would sit and debate it, and sometimes over periods of weeks, to come to a conclusion that they felt they could live with.
And when you became a consultant in 1985, and during your registrar years, were you aware of any significant changes in practice in terms of the amount or frequency of transfusion?
Well, we did develop at Central Middlesex probably the exchange transfusion protocols and everything early. And my colleague, Dr. Militia Brozovic, who sadly died in December, and I wrote one of the earliest papers on sickle chest syndrome, which was in the Lancet, and how exchange transfusion could save their lives. So I think we developed it steadily, but we were at the cutting edge. But we were careful. I didn't like doing it.
And so would it be fair that during the early 80s and through the 80s there was an increase in transfusion with sickle cell patients?
Yes, there will have been.
Could we turn to RLIT 40806, please? These are a set of guidelines on red cell transfusion in sickle cell disease, and I'm very conscious, Professor Davies, that these were published in 2016, so only very recently. Before we look at some of the detail of them, were you aware of any national guidelines before 2016 in relation to sickle cell?
No, I'm not aware of any national guidelines. Of course, Kate Ryan was, first of all, my senior registrar, and then my colleague consultant, Gavin Cho, took over when I left. So I know many of these people.
But you're not aware of any national guidelines before these? If we could just pick up on the bottom right-hand column of this page, key recommendations. Consideration of sickle cell patients for transfusion, particularly long-term regimens, should weigh up the potential benefits against potential risks. And then it deals with cerebrovascular disease. Regular transfusion to maintain HbS less than 30% should be offered as initial treatment to children with SS or S beta thalassemia, aged 2 to 16 years, judged to be at high risk for a first stroke on the basis of transcranial Doppler ultrasonography. Does that represent or accord with the practice when you were in practice?
That was what we developed. I was quite au fait with what the Americans were doing. I went to the American Society of Hematology, to the sickle cell sessions. One of the people who did a lot of the work on this was Wycinski at just north of Berkeley, Oakland. And I knew what they were doing. I read their things. And yes, that was our practice.
And then if we turn to the next page, I'm going to just read out a number of chunks of the guidelines and then ask you a question about it, Professor Davies. First of all, on the left-hand column, long-term transfusion to maintain HbS at less than 30% is recommended for the prevention of recurrent ischemic stroke due to sickle cell disease in both children and adults. And then if we go down to the heading surgery, preoperative transfusion is recommended for SS patients undergoing medium-risk surgery, e.g. abdominal tonsillectomy, orthopaedic. Preoperative transfusion is recommended for SC patients undergoing medium-risk surgery, and transfusion is recommended for sickle cell patients of all genotypes requiring high-risk surgery, cardiovascular or brain. Just pausing there, in terms of those two recommendations, does that accord with your practice in the 80s?
The first, yes. This on surgery, for me, is interesting. The medical world split in two, those who believed in transfusion preoperatively and those like me who were very wary of it. But there was one study from Wycinski, and it wasn't a very good study. And we, because our anaesthetists and surgeons were used to sickle, did do less pre-op transfusion than many people, actually. And then I helped Joe Howard, Dr. Joe Howard, set up the study that happened after I stopped looking after patients that has given rise to this. I still worry, because I think if you've got minor surgery like a tonsillectomy, you may not need it, but I do think for a replacement joint, you give the new joint the best opportunity of healing if it's getting lots of oxygen rather than getting sickling in it to start with.
So would it be fair that in the 1980s and 90s when you were practicing, you weren't undertaking as much preoperative transfusion as might be suggested by these guidelines?
Probably a bit less.
And then if we go down, the guideline addresses emergency surgery. For patients requiring emergency surgery, the urgency and complexity of the procedure should be taken into account in the timing of perioperative transfusion. Simple transfusion should be given preoperatively if haemoglobin is less than 90, provided this will not result in undue delay to surgery. If transfusion is likely to cause an unacceptable delay to surgery, it's reasonable to proceed to surgery while arranging to transfuse the patient intra- or post-operatively if necessary. Again, in terms of your practice in the 80s and 90s,
we would have blood ready, but the operation, if it's emergency, would have gone ahead, and we would have looked at the bleeding level. As I've said, I would not be pushing or sanctioning transfusion if the haemoglobin was 9. That's a normal haemoglobin for a sickle patient, and I would want to see whether there was bleeding or any other reason why that patient should receive a transfusion. And that depends on why they were having surgery and everything.
And then if we go to the bottom of this column and over to the next column, acutely ill patients, transfusion is recommended and may be life-saving in acute sickle complications such as splenic sequestration, hepatic sequestration, aplastic crisis and severe acute chest syndrome. Transfusion should be considered in the unwell patient with acute multi-organ failure, mesenteric syndrome and patients with severe sepsis. Such cases should be discussed with the specialist haemoglobinopathy team. Transfusion for other causes of acute anemia requires individual assessment and should be discussed with the SHT. Transfusion may be given by simple transfusion, top-up, or exchange, depending on clinical severity under the guidance of the SHT. Again, same question, during the 1980s and 1990s, how similar was your practice?
This reflects my practice then, and it was very difficult. I mean, there are some patients that live with us throughout our lives, and I still remember one where he had multi-organ failure, and we'd exchanged him and he had less than 20% hemoglobin S, but he was still dying in front of us, and he did die. And we don't know why he died, because once you've exchanged the blood, you hope that you've washed out the sickle. And most of his blood tests were normal, yet he died. It's a horrible disease at its worst.
In terms of the risks of blood transfusion, you've said today and in your statement that you took the view that experts were ensuring the blood supply was as low risk as possible. Were you aware then of when screening of blood, for example, for hepatitis C, was introduced?
I will have been, but with my problem with dates, I can't date it for you. But of course, through the general haematology education sessions I attended, the fact that haematologists of our region met together for audits 3 times a year and therefore talked about changes, I will have been aware.
Did you have any discussions within that group of people or with the regional transfusion director about the extent and limits of screening? So difficulties with screening?
I don't recall any, but I mean, clearly we all are aware that if you're doing antibody screening, you can have an infection and be infective before the antibodies start, that if you're looking for the actual infective organism, you can get it earlier, but actually you can still be infective. There is an infective, non-pickable up area, and science has steadily made that shorter and shorter. And I think I was well aware of that.
And do you recall any discussions with the staff of the Regional Transfusion Centre about limiting the use of transfusion, or about the advice about transfusion-related hepatitis?
So, I mean, I think we all wanted to limit transfusion at a certain point, but I can't date it. Transfusion committees were set up, and I remember that ours was probably one of the early ones, because my senior colleague was seen as being a leader in transfusion in district generals, and that was one way to bring other clinicians into the discussion and update them. Did I answer all your question? No.
The inquiry's heard evidence that for certain regional transfusion centres, they have indicated that they came into the hospital and did talks or seminars or workshops with clinical staff at the hospital, or they went on grand rounds. Do you recall anything of that happening at the Central Middlesex?
No, I don't recall, but that doesn't mean it didn't happen. They didn't come to a grand round. We had regular training sessions for the haematology department, including the technicians, the MLSOs. They may well have come, but I don't recall it. And we were supported by one of the best transfusion centres in the country. So if that was happening, it would be odd if we weren't part of it.
You've said in your statement that the department was scrupulous about following the British Committee for Haematology guidelines. It may seem a very obvious question, but how did you come to know that a guideline had been published?
Well, I was not in charge of the blood bank. For most of my time, Dr. Brozovic was. But, I mean, we would scan the British Journal of Haematology. Most of them were published in that. Some were published in other journals, but she kept an eye on those. And, of course, the network would be, I mean, the guidelines were all written by colleagues, so we knew what they were working on, and we knew when to expect them. I expect also that the Transfusion Centre sent them round everyone, but I would not have been the one that received them.
You would have relied on your colleague to pass them on to you?
To take the action that our hospital needed to take. You can't do everything.
In terms of the supplies of red cells for transfusion and indeed also fresh frozen plasma, you say in your statement that the department held supplies. Very practically, were those supplies held in the haematology unit, or were they held in the hospital blood bank?
The hospital blood bank was part of our laboratory. So you walked in and the blood bank was on the right, the main haematology lab was next, and then there was a hemoglobin lab, and then initially there was a chemical pathology lab at the end of the corridor.
And in terms of the paperwork that was used to obtain blood, you've said that if you were requesting blood or platelets from the blood bank, then there'd be a written form that was sent to the blood bank. Was the reason for the transfusion recorded on that form, as far as you can recall?
No, I'm not sure it was.
What records did the blood bank then keep in relation to blood that was supplied?
The blood bank kept the records of the request, which was the details of the patient hospital number, we didn't use NHS numbers, name, date of birth, the consultant in charge, the ward that they were on. The blood bank would keep the cross-matching records, what they'd tested, and then what they had marked up as for that patient, and then whether it was dispensed, which meant that it was taken from the fridge by someone who was allowed to, that they had matched the numbers of the patient with the units, and we would know who had picked it up and at what time, because they had to sign a book, and that was kept. There were sticky labels that then had to be put in the patient's notes. If the blood was not used, which was a rare event, then they were expected to send it back to the blood bank, and it was recorded as received back, and I think returned to the transfusion centre, but for disposal, but I'm not certain.
And so in terms of what was then in the patient's notes of having received a transfusion, there would be a sticky label indicating the unit details?
Yes.
Was there any handwritten note as well? Or just
Well, that depends on the clinician. For our patients, there would be a handwritten note of why we were doing a transfusion, how many units, and what our objective was. And then the nurses who put the blood up would have to sign the sheet and date and time it for the medication sheet. So that would also be kept in the notes for years to come.
I want to move on to the information that you gave to patients about transfusions. When a patient needed either a top-up transfusion or an exchange transfusion, what information did you give them about the risks of a transfusion, particularly the viral risks?
Well, the discussion was always about risk-benefit, and if you've got an aplastic crisis or a splenic sequestration or chest syndrome, then you're very likely to die without transfusion. So the conversation was shorter, but the benefits were very much more clear. I think we went much more into the long-term consequences, including particularly iron overload and mentioning infection. But the infection risk was quite low. The blood was tested, and so we did not make a big issue of that, but I believe we said, and of course, infection can be transmitted.
You've said in your statement that there wasn't a process of formal consent to the transfusion. By that, do you mean there wasn't written consent or there wasn't consent? Can you help us with what you meant by that?
There was no form, there was no set number of things that one should discuss. It was an informal conversation between the treating clinician and the patient that was, I don't think, recorded in that way in the notes. I think we'd say, I would go and write in the notes, transfuse or exchange transfuse, aim this. But we would not give a treatment to a patient, and blood is a treat, and its products are treatments, without discussing it with a conscious patient and making sure that they were accepting of it.
You've again said in your statement that no sickle cell patients at the Central Middlesex who had been transfused in the UK were infected with HIV. Is that right?
I'm not aware of any patients in our clinic who acquired HIV or hepatitis C for that matter.
That was my next question. I just want to understand the hepatitis C point a little more, or explore that a little more with you, Professor Davies. In terms of the following up of sickle cell patients in clinic on a routine basis, putting to one side when they're in a crisis, but on a routine basis, how frequently would you see a sickle cell patient, assuming they attend when they should?
Well, we asked them to come every 6 months. Many of them didn't, and I absolutely understand why they didn't. They saw enough of us when they were sick. They didn't want to see us when they were well. So some would disappear for years and then reappear because they were ill. Some would move out of the area and then reappear and say, I'm back visiting, so I've come to see you. I mean, it was not as kind of regular as it was for, say, leukemia patients or other patients. But of course, there were the frequent flyers who we saw very regularly, and because they needed our support and care.
Before hepatitis C testing was available, were liver function tests routinely undertaken?
Our patients would have their liver function tests checked at least annually, if not every 6 months, but they wouldn't classically, in sickle cell, they're not normal. They will have raised bilirubins, quite often an abnormal gamma GT or ALT and things. So they're not, the fact that they were abnormal doesn't make you think, oh, something's new. What we were interested in is how abnormal, and particularly compared to before, so that when we saw them when acutely ill, you'd know if they'd changed. But regularly, or quite often, they were abnormal.
Within that assessment of the abnormality of liver function tests, were you looking for anything in relation to possible hepatitis C infection?
No.
Once hepatitis C testing was available, was there any routine testing of patients with sickle cell for hepatitis C?
No, I'm not aware of anyone who set out to test their whole clinic.
Why was that?
Well, I think that we had a group think that the blood was tested and therefore the risk was low.
But for those patients who had received transfusions before hepatitis C screening came in, was there any consideration given to testing those patients for hepatitis C?
Not that I recall, but I thought that with the look-backs that were going on, if any were at particular risk, that we would pick them up.
And do you recall whether any patients in the clinic were identified in the look-back?
I recall that some look-back letters came to Central Middlesex that my colleagues then went to find the notes and the clinicians, and it was all sorted out, but I did not receive any of those, and I don't recall receiving any at all to do with my sickle patients.
Did that surprise you?
No.
In the context of patients who've received regular blood transfusions and quite significant quantities of blood, might one have expected some of those units to have been identified in the look-back?
Well, I think you and the experts will be much more on top of the data than I am. I was not surprised at the time.
And in terms of your awareness of the look-back exercise, did you have, or did the department have discussions with the Regional Transfusion Centre about the extent and perhaps the limitations of the look-back exercise?
My colleagues in charge of the blood bank may have had those conversations. I was not party to it, that I remember, but I don't think it was.
Moving, let me just check the time. No, we're okay. Sorry, sir. I always make that mistake in terms of the first break, but we will continue on to one more topic before we take a break. The inquiry has heard some evidence, or read some evidence, about the significant stigma for some communities around having sickle cell disease. What was your experience in that regard?
I think there are two issues here. Is having an inherited disease a cause of stigma? And I think it can be. It can be a cause of guilt for parents. It can be very difficult. And so within families and communities, you can have that. But then you get into the issue of race. And it is very interesting, or it was to me at the time, that the big hospitals that had significant sickle cell populations, the teaching hospitals, did very little research on it. The haematologists were all either doing clotting disorders or leukemias and lymphomas, and somehow it was the Cinderella specialty. I I and my patients and community, we had a very active patient support group in central Middlesex, worried that that might be institutional racism and that this might be stopping patients getting bone marrow transplants as curative therapy as time went on in the 90s. In order to try and explore that, I actually set up a moot. So I persuaded 3 QCs to give their time free. And on a Saturday, we tried the case that more transplants should be available for sickle cell disease patients. We had a jury where the mother of a child who died of a sepsis, a public health doctor and a patient. We flew in some experts from the States, and we had 2 witnesses on either side that were really put onto interrogation by the QCs. And at the end, and with a big audience from the community as well as medical, nursing and everything. And at the end, the view was that actually the professions were being very careful and that one shouldn't go forward to bone marrow transplant like that. What we needed to do were studies and do it very carefully. Of course, different ways of doing transplants have come since, and now they are practiced much more. So I did try and test the racism and get this kind of discussion opened up to make sure my patients were getting the best. It was actually written up in the British Medical Journal to try and make sure that everyone thought about these issues. Does that answer your question?
I'm going to return to my previous question in just a moment. I want to carry on in relation to the race issues that you've raised. I've also been asked to ask you whether you think that the funding for and care of sickle cell patients was influenced by the fact that the majority of sufferers are from a sub-Saharan African or Caribbean background.
I feared it might be, because if you looked at the money spent on haemophilia patients and the numbers, the discrepancy was unfair. If you looked at cystic fibrosis patients, they had specialist centres and much more funding. It seemed unfair. So I was concerned about the fairness of it and did my best to make sure that our patients, and nationally, we gave the best we could. And that, of course, was some of the thinking underpinning that Standing Medical Advisory Committee report that you have uncovered.
Which I'm going to go to in one moment, but before I do, were other health inequalities associated with ethnicity and race? Do you think they were fed into the treatment options for sickle cell?
I know quite a lot about health inequalities as a result of being CMO, but I'm not sure I understand quite what you're getting at there.
I'm sorry, it's a question I've been asked to ask you, whether other health inequalities associated with ethnicity and race fed into the treatment options for sickle cell.
So many of my patients lived in poor conditions. They lived in housing that was not satisfactory. And of course, it's difficult with any chronic disease to live in poor conditions, but if actually you've got sickle cell, you need to try and prevent infection, you need to be well hydrated, you need to be kept warm, and to live in accommodation that was crowded, stressful, and drafty was not good for the disease. So it kind of played out in those ways. It was difficult, yes. Poverty and inequalities do not help.
Could we turn then to the report of the Working Party of the Standing Medical Advisory Committee? It's SCGV 40267_152, please. Again, it will appear on your screen. And we can see in a subsequent page that this was published in 1993. And I want to turn to page 6, please, of the, it's page 9 internally. Professor Davies, if you want to go to your own copy, but it's on the screen, the executive summary. We see here that the Secretary of State for Health invited the Standing Medical Advisory Committee to consider various aspects of haemoglobinopathies in order to ensure more even provision of health care. And a few paragraphs down, this working party has sparked a tremendous amount of interest from health professionals, both individuals and professional bodies, people with haemoglobinopathies and their families, members of populations at risk, and relevant voluntary organisations. This concern was reflected by the large number of people and organisations who submitted written evidence. And if we could go further down, please. It was clear from both oral and written evidence that care for patients with haemoglobinopathies and genetic counselling of populations at risk is not always of the highest quality, even where these disorders are frequently seen. Professor Davies, do you have any views on that, those findings of the advisory committee?
I agreed.
There's no reference whatsoever in the Working Party report to HIV, hepatitis B or hepatitis C, either in terms of diagnosis or recommendations for treatment. It might be suggested, therefore, that blood-borne viruses were not really on the radar for this group of patients. Was that the situation, or is there some other explanation of what was happening?
Well, I was not on the committee, though my senior colleague, Dr. Brozovic, was. There is concern mentioned, I think, on iron overload. I think what was going on was trying to pick off the priority issues, get attention on this group, improve services, you know, and it was pretty patchy across the country. A lot of patients from around the country would come and see me once a year or something, and my standard consultation started with, this is really difficult for you because not only are you ill, but you know more about your illness than your doctors will ever know. And by the time we've finished, you will know an increasing amount, and what we have to discuss is how do you handle a doctor when you know more than they do? And that was a routine. I saw a lot of patients who were children of diplomats here in London and other patients who came from abroad to see me. But what I think this SMAC report was getting at was we hadn't even got to the starting base for these patients. And let's get there, and then you can begin to focus on less common issues. So its mission is now very interesting with a retrospectoscope, but actually the priority was to get decent services in place and then start to look at other things.
In terms of going back to my first question in relation to stigma, you spoke about the difficulties of having a genetic disease. Were you aware of any other individual and personal experience of stigma for those suffering from sickle cell?
Yes, it happened every few years, probably every couple of years, that I would meet a family where the mother had been accused of hitting her child or not caring for the child properly, because one of the first presentations up to 18 months of life is sickle crises in the long bones, the metacarpals, or the metatarsals in the feet, and then you get red swelling over it. It's called the hand-foot syndrome. Now, if you don't know it happens and you're not thinking about it and you don't test for sickle, then you think that child has been damaged. And so a number of mothers would be falsely accused, and it would only be discovered time later. So, yeah, there were difficulties in drawing it to people's attention and making sure that patients were effectively diagnosed at first presentation.
And in terms of psychosocial support for those patients, what was provided within Central Middlesex?
We, from the Brent Sickle Cell Centre, which was the first in the country, provided a counselling service that staffed by wonderful expert nurses who would interact with the families, explaining, helping. They would go into schools to explain and support and ask for extra education. They would elicit what the problems were, and so I often wrote to housing on their behalf. I actually wrote on behalf of a number of patients to the police when they seemed to be picking up my patients who had not been misbehaving. So we would do our best to support on housing, on welfare. There were some benefits that if the children or adults were badly affected, they could get, and we would write the appropriate letters if it seemed right.
And in that, within the Brent Centre, how involved was the centre in providing additional information and advice about the risks of transfusion beyond what you'd done in clinic?
I'm not aware that they were involved over and above what we did in clinic, though they will have known what we did in clinic because nurses often sat with us to make sure that the patients were not overawed by the doctor or that they remembered in the heat of the moment to say things. I should also say that I got the grants to start a psychosocial support system with counselling support and everything too for them, which started in the early 90s.
So I'm about to move away from sickle cell care to a different topic, and I note it's almost 11:15. I wonder if now's a convenient moment to break.
Yes, just before we do, if I may, one of the features of some of the evidence which we've had early in this inquiry, indeed it was raised with me 3.5 years ago when we had preliminary hearings by at least one of the representatives of core participants, was that the real expert they were talking about haemophilia, was the person who had haemophilia. And it was sometimes very difficult to persuade doctors that they knew something about haemophilia. You asked the question, or raised the question, how do you handle a doctor when you know more than they do? What is the answer?
Well, it isn't easy. And doctors often don't like to be corrected, so I would talk to them about ways of raising issues with and how to be assertive rather than aggressive, and how to bring different issues in, and how to use me as a bulwark to protect them. You know, well, Dr. Davies said, and things. So I would try and do that. There are two differences between the haemophilia group and my sickle group. My sickle group lived with the disease as it in its raw nature and only had transfusions to modify it, whereas the haemophilia patients at this period were generally getting factor VIII in one form or another and may not have seen what it was like to have haemophilia before treatment and the horrors of that. The same would be said of thalassemia major, that, I mean, I have seen thalassemia major in Greece untreated and in Africa, and how horrible it is. But the thalassemia major patients who are transfused have lost that kind of social memory of both diseases, what it's like if you don't treat. And the doctors now don't have that social memory either. In that discussion of how you deal with a doctor who when you know more than they do, the underlying assumption is that the doctor is saying, look, do this, do that, take this treatment. Is there an issue here about the extent to which medicine, at least then, was more dictated to the patient than discussed with the patient? Yes, I think we have changed over the decades to more transparent, no decision without me, and putting the patient there. Why would I have been earlier in this? I came from an academic background where debate and discussion really mattered, and I respected my patients. I respect them awfully, to live with what they lived with. They are amazing.
It brings me back to what has been a theme in recent weeks in particular, which is the extent to which clinical freedom enfranchises or frees the patient rather than it gives the doctor liberty to do what he wants to the patient. You have a particular perspective as having been CMO on this, I have no doubt. Do you want to comment?
I think we have an interesting balance between clinical freedom and trying to do the best thing for that individual patient, which should be a discussion, and may, if innovation is there, be different from the guideline, and which is the best evidence that we should be using for the majority of patients. But you will remember that when I talked about going on the hunt every morning for the doctors who'd admitted my patients overnight, I said, if they departed from the guideline for good reason, I congratulated them. That's clinical freedom. It's knowing what is the best evidence and then saying at the time, but does that work for this patient? And if the patient is able to discuss it and say, well, normally we'd do this, but this is where we are. But I do think that transparency and debate has shifted over the decades for the better.
Thank you. Well, we'll take a break, and it's until 10 to 12. This is the first break. You're giving evidence. You may not discuss the evidence you have given or any evidence which you think you may yet be asked to give with anyone, whoever that person is, but you're free to talk about anything else you like.
Thank you very much.
10 to 12, please.